Welcome to the Intensive Services Foster Care and Therapeutic Foster Care webinar. Today's webinar will focus on understanding the differences between ISFC and TFC. The webinar is part of CIBHS's technical assistance work with the Department of Healthcare Services. Today's content is designed to assist county systems and providers with understanding TFC and ISFC requirements, including the similarities and differences between them, and how ISFC and TFC may be leveraged to support children, youth, and their families. Before I turn today's presentation over to our first presenter, we have 3 polling questions which we would like you to answer. This helps us to get a better understanding of our audience today. If you are logged into a computer or tablet, you can click on your response after each question and we will share the responses with you. So number 1, please tell us what area you represent. Child welfare, behavioral health or mental health, a contract agency, CBO, provider, juvenile probation, or other. So please click your response. We're going to open the poll and then we'll tell you the response. Okay, we're going to close the poll and read the response, and Kelly will read the response.
We have 37% of child welfare, 26% in behavioral mental health, 23% contract CBO or providers, and 4% of juvenile probation, and 10% other.
Great.
So thank you.
Thank you. Our next polling question is, please let us know your agency's current status around implementing intensive services foster care. Not implementing ISFC, planning to implement ISFC, we currently provide ISFC, or not applicable. So Kelly will open the poll now and click on your response.
About 70% voted, so close it.
Okay, we're going to close the poll.
And we have 9% not implementing, 49% is planning to implement, 22% is currently providing, and 19% is non-applicable.
Thank you. And this is our final polling question. Please let us know your agency's current status around implementing therapeutic foster care, or TFC. Not implementing TFC, planning to implement TFC, we currently provide TFC, or not applicable. Poll is open.
Okay, I'm going to close the poll.
All right, poll is closing.
And we have 14% not implementing, 52% planning to implement, 12% is currently providing, and 22% not applicable.
Great, thank you. So it's a privilege to have with us 4 presenters. Teresa Castillo and Cindy Culkin will be presenting for the Department of Healthcare Services, and Cheryl Treadway and Daisy Braxton will be presenting on behalf of the Department of Social Services. And here are our objectives today. Number 1, to assist counties and providers in their continued implementation efforts related to therapeutic foster care and intensive services foster care. And number 2, provide information regarding TFC and ISFC requirements, including the similarities and differences between them, and how ITFC and TFC may be leveraged to support children, youth, and their families. So at this time, it's my pleasure to turn over the presentation to Teresa Castillo and Cindy Culkin to discuss TFC.
Thank you, Kim, for that introduction. This is Teresa Castillo from DHCS, and good morning, everybody. Thank you for taking time today to participate in this webinar. Really appreciate that. As both departments, the Department of Healthcare Services and the California Department of Social Services have implemented both therapeutic foster care and intensive intensive services foster care, respectively, we have received frequent questions and often requests for information about the differences and similarities for both TFC and ISFC, specifically how the two intersect with each other. Today you will hear from both departments, and I hope that this information will assist you as you move forward with your implementation activities for either or both TFC and ISFC. Content-wise, we will cover information for TFC and ISFC, and then we will walk through a side-by-side, which we see it as a core piece for today's webinar. I will start by covering some background information for TFC, and then I will turn it over to Cindy Culkin, who is my team's lead on TFC. As many of you know, as a result of the KDA settlement agreement, both departments have been involved in various activities and efforts. For DHCS, implementation of intensive care coordination, intensive home-based services, and TFC has been a key effort in this process. Both intensive care coordination and intensive home-based services have now been implemented for a few years. And now we're moving forward and focusing on the implementation of TFC. As many of you know and were participants in the process that we had, the departments have been working for months now to develop the TFC model. Many of those stakeholders, many of you are actually part of today's webinar. So again, thank you for helping us through that process. Today, we know that many counties and many of you, and as we heard from the polling question, are moving forward with implementation of TFC. And we're very excited to hear that. So with that, I'll then turn it over to Cindy Culkin, who will walk us through some of the slides on TFC. We will walk through the slides a little bit quicker because we want to make sure that we allow ample time for that side-by-side and also for Q&A. With that, I'll turn it over to Cindy. Cindy, please take it away.
Good morning, everyone. This is Cindy Culkin, and I appreciate this opportunity to speak with you about TFC, also known as therapeutic foster care. TFC is available as an EPSDT benefit to children and youth under the age of 21 who are Medi-Cal eligible and meet medical necessity criteria. As you probably already know, TFC is short-term, intensive, highly coordinated, trauma-informed, and individualized to meet the needs of each specific child or youth in TFC. TFC is intended for children and youth who require intensive and frequent mental health support in a family environment. TFC should not be the only specialty mental health service, or SMHS, that children and youth receive. Children and youth who are in TFC also should receive intensive care coordination, or ICC, and other medically necessary specialty mental health services, or SMHS. In addition, there must be a child and family team in place to guide and plan the provision of TFC services, and the child's or youth's progress in TFC should be reviewed in coordination with the CFT at least every 3 months and as needed. In summary, TFC is provided by TFC parents under the supervision of a TFC agency, typically a foster family agency, and under the direction of a licensed mental health professional or a waivered or registered mental health professional employed by the TFC agency. The TFC agency is responsible for ensuring that the TFC parent meets resource family approval, or RFA program standards, and that the TFC parent also meets the required qualifications of a TFC parent.
You go back one?
Yes.
Sorry.
One-
We'll go back. Here we go.
The licensed mental health professional or the waivered or registered mental health professional employed by the TFC agency directs the TFC parent regarding the interventions that parent uses as identified in the child's or youth client plan. The mental health professional also meets with the TFC parent a minimum of 1 hour per week face-to-face in the TFC parent's home, and the mental health professional employed by the TFC agency is responsible for reviewing and co-signing daily progress notes completed by the TFC parents to ensure that each progress note meets Medi-Cal specialty mental health services and contractual requirements. The TFC parent must be 21 years old and have either a high school diploma or a high school equivalency degree. The TFC parent also must meet and comply with all basic foster care resource parent requirements and meet and comply with all requirements and training related to the role of the TFC parent. This training includes a mandatory 40 hours of initial training that the TFC parent must complete prior to the provision of TFC services. TFC parent training also includes 24 hours of annual ongoing training. As I indicated previously, the TFC parent must write and sign a daily progress note for each day that TFC is provided. Without the progress note, there is no payment for TFC services. The progress note must meet Medi-Cal documentation standards, and the TFC agency must comply with the mental health documentation requirements prescribed by the contracting county mental health plan in accordance with the contract between DHCS and the MHP. The unit of service for TFC is 1 calendar day, and a calendar day or the TFC per diem may be claimed only for each calendar day in which TFC is provided. The per diem rate for TFC includes 3 different types of costs. The first type of cost included in the per diem rate for TFC is the TFC agency's administrative cost pertaining to the administration of TFC. The second type of cost included in the TFC per diem rate is payment for to compensate the TFC agency for the staff costs incurred based on the need to employ a licensed mental health professional or a waivered or registered mental health professional to direct the TFC parent. And the third cost covered by the TFC per diem rate is payment to the TFC parent for the provision of TFC services. The interim per diem rate depends on whether or not the TFC agency is a contractor of the MHP or is county-owned and operated. If the TFC agency is a contractor of the MHP, the TFC agency is paid by the MHP at a rate that is negotiated between the MHP and the TFC agency. If the TFC agency is county-owned and operated, DHCS reimburses the MHP the federal share of the MHP's interim rate. As of March 2017, the county interim rate for TFC was set at $87.40 per day. And as you may know, each county's interim rate is updated annually based on its most recently filed cost report. I'm going to conclude my presentation by talking about 2 resources that will be helpful to you in planning your TFC program. And the first one is the Medi-Cal Manual for Intensive Care Coordination, Intensive Home-Based Services, and Therapeutic Foster Care for Medi-Cal beneficiaries. This is the third edition of the manual and the only edition of the manual that includes information pertaining to therapeutic foster care. The Medi-Cal manual, just briefly, Chapter 1 contains information about the purpose and background of the manual. Chapter 2 details the target population to be served by TFC, ICC, and IHBS. Chapter 3 discusses the integrated core practice model framework, which is to be used to deliver TFC, ICC, and IHBS to medically eligible children and youth. Chapter 4 describes the composition and functions of the child and family team in the delivery of TFC, ICC, and IHBS. And Chapter 5, which is probably the lengthiest chapter of the manual, contains detailed descriptions of ICC, IHBS, and TFC service components, activities, provider qualifications, service authorization, and coordination of each of these services with other SMHS. Chapter 5 also contains examples of how to plan within the CFT to provide ICC, IHBS, and TFC. And Chapter 5 contains vignettes pertaining to 3 trauma-informed TFC case examples that link to the sample TFC progress notes contained in Appendix C. Likewise, Appendix B contains sample ICC and IHBS progress notes that build upon the examples for ICC and IHBS that are contained in Chapter 5 of the manual. And one last thing, I just want to point out that the sample progress notes that are contained in the Medi-Cal manual contain very detailed narrative sections with multiple examples. And we chose to use this lengthier, very detailed narrative format as a learning tool to provide the reader with several examples of the types of appropriate information to be included in TFC, ICC, and IHBS progress notes. The second resource that I would like to discuss, and I'm just going to be pretty brief with this one, is the Therapeutic Foster Care Parent Resources Training Toolkit. And the toolkit was jointly released by DHCS and CDSS in December 2017. The toolkit provides information pertaining to the 18 required TFC training topics, and each training topic also has learning objectives so that the reader will have an idea of the skills and abilities we want the TFC parent to acquire as a result of completing this training. There will be a webinar for the TFC Parent Training Toolkit on June the 28th, hosted by CIBHS, and everyone who's registered for this webinar will receive more information about the upcoming webinar, so I won't waste your time discussing the toolkit in detail at this point. Again, thank you very much for participating in this webinar, and thank you for your time listening to my presentation, and I'm going to turn things back over to Teresa Castillo.
Thank you so much, Cindy. In terms of implementation of TFC and actually also ISFC, we know and acknowledge and have heard from counties and providers that recruitment of foster parents is a key aspect in a challenge in and of itself in terms of having foster parents that then can be either or both TFC and ISFC parents. So to that effect, there are several efforts underway, one of them being an example of an effort led by CDSS in which the department has contracted with Dr. Denise Goodman, who will be providing regional trainings, and actually I think trainings have started already throughout the state. Dr. Goodman will be assisting counties with the specific activities and techniques for recruitment of foster parents. So I just wanted to make sure that we highlighted that today and mentioned that today, since that's going to be a key aspect, again, for moving forward with both TFC and ISFC. In regards to TFC and kind of completing this first few slides on TFC, I wanted to conclude with sharing with all of you a little bit about where counties are with implementing TFC. And as we heard from the polling, we know that many counties are moving forward with implementation of TFC. We know that many have released requests for proposals. Other counties are in the process of releasing requests for proposals. We know that many counties have actually now contracted with providers, with foster family agencies to provide services. And we know that others are looking at leveraging their existing structure, either existing contracts that counties have with FFAs, to really build on that. We also know that many counties are actually looking at providers or foster family agencies that have historically implemented ITFC or are now implementing ISFC to build onto that to then be able to provide and implement TFC. We also have heard from some counties, some of them more rural and or smaller counties, about some particular challenges in regards to lack of foster family agencies, and we have had discussions too about that and seeing if there's a way to find a solution to that, whether that is working with FFAs that are interested in having a business or an office in those counties. So with that, we know that counties are in various stages, but definitely have heard that counties are moving forward and very excited about that. And again, hoping that the information from today's webinar will really provide clarification about ISFC and TFC, because we really see them as building upon each other and leveraging each other to implement and move forward with both. So at this point, I'll turn it over to Kim, who will lead us into ISFC.
Great, and thank you, Teresa and Cindy. So now I'm going to turn our presentation over to Cheryl Treadway and Daisy Braxton from the Department of Social Services, and they're going to discuss ISFC.
Thank you. So this is Daisy Braxton, and I'd like to walk you through the Intensive Services Foster Care Program. The Intensive Services Program was established by Assembly Bill 404 in 2017. Intensive Services Foster Care, ISFC, I'll refer to from now on, is a private, nonprofit, or public agency program model of home-based family care for eligible children whose needs for safety, permanency, and well-being require specially trained resource parents and intensive professional and paraprofessional services. Just want to also reiterate that the ISFC is a statewide program, and it no longer requires a memorandum of understanding with counties, referred to as an MOU. Intensive Services Foster Care is more than just a rate. Continuum Care Reform, CCR, is intended to support all children in home-based care. Every child deserves a home. Case planning and needs and services plans should ask,
what is needed to make this child and family successful. Under ISFC, families are intended to be supported with more than just a rate. Children and families at this level of care are expected to be supported with ongoing child and family team CFT as needed to support placement stability, coordination of specialty mental health services. Agencies should be familiar with the full array of how to access the system. Respite care, including natural supports, trauma-informed and permanency competent services, ongoing problem solving and collaboration when barriers arise. Placement and eligibility. Those who are placed and eligible are minor or non-minor dependents in foster care who have intensive needs such as medical, therapeutic, or behavioral needs. The following are eligible to accept ISFC placements. Resource families are considered foster family homes, including those taking care of children with specialty health care needs. Homes certified by an FFA, including a public delivery model. County-approved relative homes, including approved relative caregivers, non-relative extended family members. Non-related legal guardians and kin gap guardians are not eligible to become ISFC resource parents. ISFC children and youth in a home in terms of capacity. There should be no more than 2 foster children, one or both of whom may be ISFC eligible children. To accommodate sibling group placements, where at least one sibling is an eligible child, the home can have up to 5 total children in an ISFC home. With regard to the level of care, LOC, and the rate determination tool, ISFC is part of that matrix. Under ISFC, the tool identifies children or youth with specific needs, including the multidimensional treatment foster care that Teresa spoke of, special health care or medical placements, therapeutic foster care, or other special placements. Also, it can be time limited based on the static criteria for urgent placement needs. Urgent placement needs. Under the urgent placement read, the ISFC rate may be paid for 60 days and extended another 60 days if needed, such as the same time it can be allowed to have completed pre-placement training or during that time. In a 2-parent household, the rate may be paid for 60 days and extended for another 120 days to allow the second parent to get trained. There are 2 models under the ISFC program. One model is the FFA model that is delivered through a licensed FFA or a home county licensed by the California Department of Social Services to run an FFA. The second model is the public delivery model that is defined as an ISFC program directly operated by a county as a governmental program. Training. There's multiple levels of training. First, we're going to talk about is the resource parent training. So before pre-placement training is completed and an ISFC placement is made, the resource parent has up until 120 days after placement of a child to complete their 40 hours of pre-placement training. In the 2-parent home, the second resource parent must complete the initial 20 hours of pre-placement training within 180 days of the placement or the identification of an eligible child or youth to be placed with them to complete that 20 hours of pre-placement training within 12 months of the placement. Both parents need to continue to complete the 12 hours of annual training thereafter. All ISFC resource parents must complete the 40 hours of training before an ISFC placement is made, unless the placement is an urgent placement. in that situation, the 12 hours of RFA training does count toward those 40 hours. And again, the 12 hours of ongoing training is still required annually. ISFC agency and county staff training, excuse me, client support staff are professional and paraprofessional staff or contractors who meet the experience and education requirements that are outlined in statute. Client support staff training hours remain the same as that was previously under the ITFC program. However, training subjects can be expanded to include training that is specifically tailored to a particular population. ISFC healthcare professionals training. Healthcare professionals shall not be required to complete any training or additional training unless it is determined necessary by the child's individualized health care planning team. And we say that with emphasis because they are a professional and they have met specific training as a professional. The only requirement as such that would be needed, again, would be if there is a specialized team for the child with specialized health care needs that is necessary. With regard to the professional training that these healthcare professionals have, and if needed, their training may be substituted on an hour-for-hour basis, which is allowed under WIC 17731. And with that, thank you again for listening to this training session, and I will turn it back over to Teresa and to Cheryl Treadwell.
Thank you, Daisy. In terms of TFC and ISFC, I mean, I think that, so far you've heard about key components and elements for both TFC and ISFC. And as you can see from this slide, a key question or area of focus around TFC and ISFC is around whether or not a foster parent can be both a TFC and an ISFC parent, and whether or not they need to be both. In terms of ISFC, an ISFC resource parent may become a TFC parent if the ISFC parent meets all of the TFC requirements. However, and in addition, a resource parent may also be a TFC parent without becoming an ISFC resource parent. So as we have here on the slide, a foster parent may be both, but it is not required that a foster parent be both. We have heard that as a natural step, many counties and providers are looking at building from ISFC and building from parents who have history and have experience with ITFC before and now ISFC to build onto that and train those providers for them to become TFC parents. But again, it is not necessary for an ISFC parent to become a TFC parent, and we can also have TFC parents without them being ISFC parents. So hopefully we are being clear about that, but if there are still questions around it, feel free to type those in and we'll answer those. So a key area for today's webinar, we really wanted to capture the information that both Cindy and Daisy talked about today in kind of as a side-by-side, so we can easily, and you can all easily see the information and put it in a context where you can see them together, see the elements again in a side-by-side. So I will start with the first element here that we have, which is really how we describe both, how we think about a TFC and ISFC. So for TFC, what I will highlight from this description is that a TFC is a short-term intensive specialty mental health service, and I'm emphasizing here service, that will be provided by a TFC parent to children and youth. I also want to emphasize that TFC is not a standalone specialty mental health service. It is key and critical, and there must be other specialty mental health services that need to be provided to that child or youth. In particular, and at a very minimum, we see that a child or youth receiving TFC services must also be receiving, at the very least, intensive care coordination. So with that, I'll turn it over to Cheryl for her to walk us through kind of the key elements for ISFC in terms of a description.
Thank you, Teresa. So intensive service foster care should be viewed as a program where placement is intended to serve children and non-minor dependents in foster care. Similar in the sense that you talk about intensive treatment and behavioral supports that are provided, those could be things like therapeutic foster care, could be other services as well that are provided in the placement for an intensive services foster care program. And as Daisy mentioned earlier, how that is determined is by a level of care rate determination protocol. So the similarities that I see is that we have populations of kids that have complex needs. So that is a very important similarity.
Thank you. In terms of who's actually, who the population is, when we think about TFC and ISFC and children and youth served by these, for TFC, as Cindy mentioned before, TFC is available as an EPSDT benefit to children and youth who are Medi-Cal eligible and meet medical necessity criteria. Again, it is intended for children and youth who have complex emotional and behavioral needs. An element that I do want to emphasize here, which is a difference, if you would, between TFC and ISFC, is that for TFC services, it is not necessary for a child or youth to have an open child welfare case or be involved in juvenile probation to be considered for TFC. As the Medi-Cal benefit, it is available, again, to any child or youth who is Medi-Cal eligible, under 21, it meets medical necessity criteria. A child doesn't need to be in child welfare or foster care or juvenile probation to qualify for TFC services.
So the child's in foster care for ISFC, but the additional eligibility population here is the kids that have specialized healthcare needs. So we have expanded our program to provide more intensive needs for the kids that have medical concerns.
In regards to the number of children or youth that can be in any particular home, for TFC, the service itself is intended for children and youth who require that intensive and frequent mental health support in a one-to-one environment. And I am emphasizing one-to-one environment here from the perspective of the provider who is a TFC parent to the child or youth who is receiving the service. To that effect, there should only be one child or youth receiving TFC services in a particular home. So with that, we're not prescribing how many children total can be in the home. I think what we are saying from a service perspective is that the ideal is that there's only one child receiving TFC services from that TFC parent. I think that an exception to that may be where you have siblings, and if both children, let's say two children, if both need TFC services, that may be allowed. But again, we see that more of an exception to that, to the idea that there should be a one-to-one ratio.
So for ISFC, our limitation is 2 eligible foster children that can receive ISFC supports. And we do accommodate as well for sibling groups in terms of the total capacity of that home. Of course, the evaluation in considering whether you should have 1 or 2 eligible children also is based on an assessment or a compatibility assessment for that caregiver's capacity to be able to serve those the particular number of kids in that home. So we're assuming that the social worker will make that assessment in determining how many kids should be in that eligible placement.
In terms of the role of the TFC, of the parent, for TFC, we see the TFC parent as a rendering provider, and I know that those of you who are familiar with mental health language, you will, I think, recognize the term rendering here, but what we mean is really the person who is providing a service. So for TFC, the parent is that person, is that provider of TFC services. But of course, we have built into the model that TFC parents will be working under the direction of a licensed mental health professional or a waivered or registered mental health professional. In terms of qualifications, the TFC parent must meet other qualified provider qualifications, which is a requirement that we have for specialty mental health services for other qualified providers. The parent must also have a high school diploma or equivalent and meet and comply with all foster care resource parent requirements. An area that I also wanted to mention is that relative caregivers and non-related extended family members may become TFC parents, again, if they meet all of the requirements for TFC.
So the role of the intensive services foster care resource parent in the ISFC program similarly involves a significant commitment and involvement by that resource parent, meaning that they participate in every integral aspect of the support to that child, whether it be an intervention plan, whether it be a treatment plan. That resource parent is primary to the success of that child's placement in terms of their role. We see that this is the primary significant piece of the ISFC program. When you think about care and supervision, you talk about this is the highest level of intensity of supervision for an ISFC resource parent.
In regards to the age, I think this is one of the differences between TFC and ISFC in that for TFC parents, parents must be at a minimum 21 years of age or older.
And significantly ours is 18, so we have a younger resource parent requirement.
And in terms of the role of other staff that may be involved with both TFC and ISFC, for TFC, we have the concept of a TFC agency, which is really for most counties and in most instances, a TFC agency will be a foster family agency who will be responsible for recruitment of TFC parents, training them, overseeing them. And again, just mentioning that the licensed mental health professional or waivered registered mental health professional employed by that FFA will be key in the provision of TFC services, and that licensed or waivered professional will be working very closely with the TFC parent to guide the parent through the interventions that the parent will be providing as part of TFC services. We have built into the model that there needs to be at least a face-to-face at a minimum of 1 hour per week meeting between the TFC parent and the licensed or waivered person, and this needs to happen at the TFC parent's home. We also have, as Cindy mentioned earlier, that this professional person will be reviewing and co-signing the progress notes developed by the TFC parent.
So other staff that participate in an ISFC program, we have client support staff. That's a carryover from the prior program for ITFC. So many of the existing programs should be familiar with that. They can be professional or paraprofessional staff, or you can subcontract that work out to provide the support they need in the home to the ISFC family or the child.
In regards to the training, this has been also an area where I think we've had a lot of questions about understanding the difference between the training and the number of hours. And we used to have, I think, or this used to come up more through conversations that we were having a few months ago before the elements for ISFC, I think, were completed. I think now there is more clarity in terms of the training requirements. For TFC, a TFC parent needs to have and have taken 40 hours of training, and those hours must be completed prior to the parent being eligible to provide TFC services. In regards to the training to meet those 40 hours, the TFC resource toolkit that was mentioned earlier does include specific categories that can be used to meet those 40 hours. In terms of the categories, we've grouped them into 8 areas. And here on the slide, you can see them. We have introduction to TFC and the service system, understanding child and adolescent development and appropriate interventions, working with children and youth using a trauma-informed approach, preventing and managing a crisis, communication with children and youth and families, cultural competency, client sensitivity, parent self-care. As you can see, we've identified areas. We've identified learning objectives that must be met. However, we haven't prescribed a specific training curriculum that must be used. I think that will be dependent upon the counties and the providers and the FFAs. Some FFAs already have a specific curriculum that they use that they can then adapt to make sure that they cover the 8 categories here. And we're hoping that will be the case, and in most cases that FFAs will be able to build into trainings that they already have to again meet the requirements for TFC.
Daisy went over earlier the 40-hour requirement for pre-placement training. So our hours are pretty standard in terms of what we require for resource parents. We didn't change too much of the training required for ISFC parents. The additional topics specifically addressed that are changed, that are common to yours, is trauma-informed, because that is really the underlying new piece that we're trying to emphasize in this program and all of the training that we're requiring for resource families. So those, and I think Daisy also spoke a little bit earlier about, out of these 40 hours, we're crediting 12 of those hours toward the 40. And then we also identified that there are ways to take an ISFC child, and we allow you to have time to get that training if you do not have that training in place at the time. So if you want to refer back to the previous slide about urgent placement as an ISFC resource parent, then it outlines how that occurs for your training.
And in regards to ongoing training for TFC parents, they must also complete 24 hours of ongoing training every year, and it sounds like that's pretty consistent with ISFC.
Correct.
And in terms of documentation requirements for TFC services, again, as the Medi-Cal specialty mental health service, there must be documentation of the service provided by the parent. We have established that TFC parents will be required to develop a daily progress note and signed that as well. And I do want to emphasize that in the Medi-Cal manual that Cindy referenced earlier, we have included samples of progress notes that can be used by counties and providers. We're not, of course, requiring that you use those, but we're offering those as tools that can be used and adapted. We're hoping that is a very useful tool. We have also included in the manual as well completed sample progress notes, so you can see what would it look like for a progress note to be completed. I also want to mention that the examples that we provided may be a bit too long, but I think we just wanted to provide a gamut of examples so you can see, again, so you have them as a tool, you have them as examples.
So there's not specific parent documentation requirements in the ISFC program. However, there are places where documentation occurs about what's happening with the parent. So you may find that noted in the Child and Family Team plans, in the Needs and Services Plan for a child. So there, other than unless they're a TFC parent, there's not specific parent documentation requirements.
In terms of, again, specific Medi-Cal requirements, in terms of Medi-Cal certification, the TFC agency, and again, most cases it'll be an FFA, must meet applicable Medi-Cal specialty mental health services provider requirements, which will include having Medi-Cal certification. And I did want to mention here that the TFC home does not need to be individually certified. So we're not requiring Medi-Cal certification for the home. Medi-Cal certification will be required for the foster family agency, again, as any provider of specialty mental health services.
For the ISFC parent, as you said, as we said earlier, Medi-Cal certification is not required for the ISFC parent.
In terms of having a contract with a county mental health plan, for TFC, the TFC agency, in most cases, will be a contractor to a county mental health plan. So in that, unless a foster family agency is owned and operated by a county, in most cases, the FFA will have a contract with a county mental health plan to provide TFC services. A key point here is that a foster family agency and a county mental health plan may have a contract for TFC only or TFC and other specialty mental health services. So that will depend, that will be on a individual by individual basis and in terms of each contract and the arrangement between the FFA and the county. But that is a possibility that an FFA may have a contract for other specialty mental health services as well.
A contract's not required for an ISFC program. That's up to a county's choice, a local decision to have a contract for ISFC program.
In terms of a child and family team, there must be a child and family team for TFC to again guide and plan TFC service provision and also to provide recommendations as to whether or not TFC services should be considered in the first place.
And for ISFC, so child and family teams are required for all of kids in foster care, so ISFC placements are no different. So that is where we anchor the guidance and the stability support for the resource home and the child. So the rate for us for ISFC is a flat rate. As you know, all our programs are funded by 4E. It's the same rate regardless of whether the agency is a public model or a county model. And here you see the published rate, and that's the rate that's also receives a CNI increase every year as well. The one point I want to make is just that the rate is always paid through the FFA if there's an ISFC program. So there's not a way to bifurcate the rate if you wanted to pay it separate to an ISFC resource parent. So it's either through the county or through an FFA, currently the way we have it configured, but we're exploring other ways to grow homes when they're not associated with an FFA.
In terms of reimbursement for TFC, as we mentioned earlier, but wanted it to reemphasize it here, although not in a neat side-by-side, because we really had more language that we could fit in a side-by-side. But for TFC, the reimbursement will be on a per diem rate. So what that would look like is that a parent may provide interventions that fit within plan development or rehabilitation or collateral, or only one of those elements in one particular day. Only one progress note is needed, and the reimbursement will be on a per diem. So I know that many see that as kind of a bundled services that will be provided by the TFC parent. And again, only one rate per day, only one progress note required. And in terms of the actual rate that will be reimbursed to the parents, a difference between TFC and ISFC is that we're not dictating in terms of the actual amount of money that will be paid to the TFC parent. The FFA and the MHP will negotiate a rate for TFC that would include the components that we spoke about earlier, which will include reimbursement to the TFC parent, but we're not dictating the specific percentage or the specific amount that a TFC parent must receive from the FFA. Another component here is that reimbursement for TFC services will be in addition to the ISFC rate paid to that parent, again, if the parent is both an ISFC rate, ISFC parent receiving an ISFC rate, and a TFC parent providing TFC services. And to conclude today's webinar about TFC and ISFC, partnership and collaboration by local partners, as we are seeing with implementation of various efforts, including the Continuum of Care Reform, AB 1299, KDA, and I think this will be no different, will require close collaboration between partners, between child welfare, mental health plan, juvenile probation, to really determine the best way to implement TFC and or ISFC. The hope is that you will work together to develop an implementation plan to determine needed capacity. For example, how many homes you think you will need that can provide TFC, how many ISFC homes you think you will need, whether or not you're looking into really leveraging and building off of ISFC to then train those parents so they can also become TFC parents. So in this way, we see really leveraging ISFC on many cases and working towards implementing TFC. So again, I think like as we've done at the state level and really working through how TFC and ISFC will look like, similarly at the local level, we really see this as an effort that will be successful, again, through your collaboration and partnership and really working to make sure that we have the right service array and or placements for children and youth who are our ultimate common population.
Yes, and I can't emphasize that more. I think Teresa said it well. It's really about counties working together on recruitment strategies, even looking at child-specific recruitment. And when you think about homes, think about it in the sense of growing a home so that a child can be successful in that home, and not so much growing the home for ISFC or TFC. It's like if you could look at a home potentially in a different lens, that what would make this child successful in that placement, and what are the services that you need to bring to that home, and does this particular resource parent look potentially as one you want to consider for TFC or ISFC? That is a different sort of way to look at, how to leverage the two programs together when you're implementing and trying to collaborate and assess and identify homes for critical needs for kids.
All right, so this is Kim again, and we're going to transition to the question and answer portion of our webinar. So if you haven't done so yet, please type any question you may have in the question box of the webinar control panel, or you can email it to tfc@cibhs.org. So at this time, we're going to read the questions aloud, and then one or more of the presenters will answer. So Kelly, would you like to read the first question, please?
Sure. The first one is a pretty easy one, and it's clarifying the name. So they have heard of intensive treatment foster care, and is that the same as therapeutic foster care?
No, they're not the same. So therapeutic foster care, TFC, is a Medi-Cal service, is a Medi-Cal specialty mental health service, and ISFC?
So ITFC was the prior program, Intensive Treatment Foster Care, and with the implementation of Intensive Service Foster Care, there is no longer ITFC programs. All intensive treatment foster care programs have now transitioned to ISFC programs. So that's your distinction should be through the lens and definition of intensive services foster care now, and not the ITFC language.
Okay, the next one is a TFC. Please clarify the distinction being made between TFC services provided by TFC parents and the clinical specialty mental health services provided by MHP, mental health plan.
So in terms of, I'm going to, hopefully I'm understanding the question right. It's probably getting at the distinction or the point that we wanted to emphasize, which is that a child or youth receiving TFC services, which is a specialty mental health service, must also be receiving other specialty mental health services. The vehicle, though, or the provider for those other specialty mental health services will really depend. It may be the same FFA through other staff if they have a contract with a county mental health plan to provide other specialty mental health services, or it may actually be services provided directly by the county mental health plan or even another provider contracted by the county mental health plan. We're not dictating how the child will receive other specialty mental health services. That will really depend on each county and how they are structured and the arrangements that they have with their providers. What we are saying, though, is that a child who is receiving TFC services must also be receiving other specialty mental health services. The TFC parent, though, will only be providing TFC services. The TFC parent will not be providing other specialty mental health services. So I tried to cover as much as I could think of, but if I'm still not answering the question, if that person wouldn't mind clarifying it a little bit.
Okay. Next question. Which entity will be responsible for enforcing TFC requirements?
Enforcing TFC requirements. In terms of the oversight structure, let me speak to that. A foster family agency will be a provider working under a contract with a county mental health plan. As a contractor, the foster family agency will need to abide by certain requirements that are required of Medi-Cal providers. So that will be arranged and established through the contract between a county mental health plan and a foster family agency. Ultimately, the foster family agency is responsible for directing the services of the TFC parent, for overseeing those services, for making sure that the parent is providing the right interventions, for keeping documentation, keeping the progress notes developed by the TFC parents, and for having the right staff, again, a licensed mental health professional or a waivered registered professional who will be directing that TFC parent. So if I was to summarize all of that, from an oversight structure, the FFA will be the provider or the entity who will have ultimate responsibility for TFC services.
Okay. Can you elaborate on the medical eligibility for ISFC?
The medical eligibility for
That is
ISFC?
what is asking,
Okay.
yes.
So the children that qualify for ISFC that are considered defined as medically fragile kids in our statutes, and kids that are categorized as specialized healthcare needs kids, those that's currently right now defined in our statutes. So we basically took those definitions and criterias and coded it into the ISFC section. So I would refer them to our all-county letter to get the specifics of that, and that is our ACL 18-25 that will give them the sections for the specialized healthcare needs
And that,
eligibility.
and that letter is available in the handout section of the control panel of the GoToWebinar. For ISFC, do all 5 children need to be related to exceed the limit of 2 foster children in an ISFC home?
For now, the way the statute reads, it's 4 siblings, and so they do need to be related.
Okay, this question has a lot of acronyms that I'm not familiar with, so just bear with me. If NRLG and KINGAP guardians are not eligible to be ISFC, what happens with funding if the caregivers are a RFH and want to go to LG? Does the foster care funding have to be decreased from ISFC?
So they need to, that's a question that we'll have to get back to them on, so I can understand what the scenario is.
Thank
That's
you.
not clear for me. Because they're talking,
LG is.
yeah, I think it's legal guardian, but I don't want to assume
Okay.
that, but I would prefer that they would
Sure.
shoot that question, and we'll get back to them on that one.
How is urgent placement decided? Is it up to the counties to determine?
So urgent placement is decided based on the level of care protocol tool that we have. Let me back up the policy. So the way that policy works now, urgent placements are made based on what we call a static criteria. And those are kids that are presenting with certain conditions, and they're placed in a resource home, and we're allowed to pay that rate up to 60 days until they're able to assess that child or determine if that's going to be the placement, or if that's going to be the short-term placement, or it's going to be the permanent placement for that child. And I would direct them again to the letter that we published on the ACL 1806, and I don't know if that was part of the webinar, but that lays out the criteria for urgent placement.
Okay. The next question, does, once the child is stable and in a TFC home, does the child have to move to another home, or can this TFC home lead to permanency?
So in terms of TFC, the service itself, we envision that it will be a short-term service. However, it is important to state that we haven't defined what we see as short-term. However, at some point in time throughout the provision of TFC services, a determination will be made that the service has been successful and a child no longer needs TFC services, and or the child has not progressed, and there is a conversation about whether or not TFC services are continue to be the right service. Any of those routes, I think, ultimately will lead at some point a conclusion that TFC services is no longer an adequate or appropriate service, and the provision of the service itself will need to stop. However, that doesn't necessarily mean a placement change. If that home is the right home from a placement perspective, assuming we're talking about a child who is in child welfare and or foster care or juvenile probation that needs a placement, there's nothing from a service model that would prevent that child from staying at that home. Again, if that is, if all the other factors are there and if that's the right home for that child. So the child doesn't need to move. The placement doesn't need to be changed.
Okay, this is another, if a youth does not have an open case, how are they placed in an FFA? Is this to take into consideration guardianship? I'm not sure if they mean ISFC or TFC.
So it sounds like they're assuming that a child automatically is placed in the FFA because they're TFC eligible, which is not an assumption you make.
I agree with that. And I think that the question is probably getting at a clarification that we made in terms of that any Medi-Cal eligible child under 21 meeting medical necessity would be eligible for TFC services. It doesn't need to be a child who is in child welfare, foster care, or juvenile probation. So with that, there wouldn't be a placement, and I'm using kind of quotation marks right now. It wouldn't be a placement per se. So to answer the question, you wouldn't need a placement in an FFA. I think there will be a determination that that a child or youth needs TFC services. However, we understand that will probably raise other questions and some complexities in terms of what elements would then be different for that child or youth or for that TFC home if the child or youth is not in child welfare or probation. I think we acknowledge that, that there will be things that we will need to work through for those scenarios. However, again, as a Medi-Cal benefit, we cannot limit it to a specific population.
Okay, so another question. So the difference is that TFC is open to kids outside of foster care. If a child isn't determined by the LOC protocol for ISFC, he/she can still get TFC?
So it sounds like they're confusing our LOC tool process with the TFC eligibility criteria, which are totally two separate processes. The level of care protocol only applies to kids in foster care.
In what situation would a child receive therapeutic foster care services without having a child welfare case open?
So again, it is I think in my mind a little difficult to describe the child or youth in terms of who we would be talking about. It would be a child or youth who would need that one-to-one intervention. A key element behind availability of TFC services is that the vision is that a TFC parent would be available 24/7. A TFC parent is available throughout the nighttime. It's available to intervene at times when it's needed, like right at the moment, like one-to-one intervention. You don't wait to take your child to a specific appointment. You have training, you're able to provide interventions right when the child needs those. So it is a child that has a specific mental health needs. It's a child that would need that one-to-one, 24 hours, 7 days a week intervention. So I think I can frame it as a child who has those needs, not focusing on whether or not a child belongs to a specific population per se. I think it would be dependent upon the needs of those children. And again, bringing it back to, of course, we're talking Medi-Cal. We're talking about a Medi-Cal service. And other factors need to be met for a child to be eligible for TFC.
Okay, here's a question on ISFC. If after 60 days at the static rate, a child shows stabilization with care and services in the home, and if that child's LOC reassesses to a lower level, is it reasonable that the caregiver would stop the ISFC training and stop their special ISFC approval?
So if if they've identified that that's the placement and the ISFC, this is a child that qualifies for ISFC, that's why we have the 60 to 100 day window so that they can make assessment of whether, one, if that's going to be the permanent placement, two, if that resource parent is going to be the identified resource parent that's going to train to meet the needs of that particular child, then those are the determinations that need to be made first. If after they make that determination and they do and the child is stabilized and they conduct another level of care assessment and the rate is lower and it shows that the child no longer needs that intensive level, we would hope that the ISFC resource parent would continue to complete their training. If they were just training for that child, then my question would be, why wouldn't they continue to get those types of services? But those kinds of discussions would take place in the child and family team meeting, because that's sort of the check and balance about what's going on with the role of the resource parent and the child, and also if there's a need to do something different with the rate.
And here's a TFC question. A TFC parent must be RFA approved. The 12 RFA training hours don't count for the 40?
So in terms of the RFA hours, we haven't, I think that it is, that may be a difference between ISFC and TFC. We didn't build that RFA hours would count towards TFC because we envisioned the training needed for TFC as being unique to the sense of, that it targets providing a service. So if we go back to the list that we had in terms of the 8 categories for TFC services, they're really aimed at actually being able to provide an intervention. So that's why I think for us it was important to have those 40 hours completed prior to providing a service and have a specific training categories as well as specific learning objectives that we think a parent needs to meet prior to providing TFC services.
Okay. What is the role of the child's biological parents or other permanent caregivers during the time the child is receiving TFC or ISFC?
So for ISFC, it would be the same protocols that we follow now for kids in foster care. So the parent would be part of the child and family team if that's appropriate. So it would always be in that context.
I think that's from my perspective a little bit of a difficult question to answer because you don't know the scenario for each child or youth may be different in terms of their relationship with their family or caregivers. So I think it is a little hard to to try to think about the various scenarios and whether or not there will be an involvement of biological parents. I think it will depend on each family's situation. For both TFC and ISFC, child and family team is a critical must-have component. However, the child and family team, the participants or who those people are, it's really dependent on each the needs in situation for each child or youth.
Okay. Can a child who needs therapeutic foster care be identified through a variety of sources? CFT, SMHS provider, resource family, social worker, private therapist, probation officer, attorney, the court, family, etc. And who would typically make the service authorization for TFC?
So in terms of who can identify a need, I think any of those aforementioned people can identify a need for TFC services. However, it needs to be discussed, and there needs to be a recommendation from the child and family team. Actual informal authorization for the service itself would fall within existing authorization parameters established by the county mental health plan. So each county mental health plans, they are allowed and have specific authorization parameters for specialty mental health services. So actual authorization for the service would fall within those existing parameters or requirements that county mental health plans have.
Okay. While site certification is not required for the individual homes, when will guidance on how to certify the TFC agencies be released? The current certification protocol was last updated in 2014.
So I'm not able to speak to when the last protocol was updated. However, it would be the procedures or steps or requirements for medical certification would be the same ones that counties are currently using to certify any other providers. So certifying medical certification for an FFA shouldn't be different from medical certification from any other provider that currently contracts with the county mental health plan.
Okay. And regarding documentation, since the foster home will not be a Medi-Cal certified site, does DHCS have specific instructions regarding where the TFC progress notes should be written and stored in order to meet HIPAA requirements?
We don't have a specifics in terms of whether it needs to be whether there needs to be a specific location. Let's put that as an example. We're not dictating all the possible situations, possible family or home environments, dictating where those notes would have to, where the parent would complete the notes and how to file them or safeguard them. We do, the model does establish that confidentiality aspects would need to be abide by. So there will need to be training from the FFA or the licensed mental health professional to the parent in terms of confidentiality aspects. For example, like don't write your notes in front of other people that might be in the house, or don't leave your completed progress notes on the table visible for everybody to see. We do envision that there will need to be a process to have those notes be saved in a, for example, a locked cabinet where they're not available or inaccessible to anybody in the home. But we are leaving those specifics to those providers in the homes. We're not dictating all the possible situations or solutions to those issues.
How is the TFC model equipped to handle a change of provider, as this is a right of a Medi-Cal beneficiary?
A change of providers. I'm assuming they're asking if a child or youth requests a change and wants another TFC provider, another TFC parent. Actually, I think that's something that I think we would need to bring it back and think that through, how that would actually take place in real life.
Are they speaking provider in terms of the FFA agency provider as opposed to the resource parent provider?
Probably the parent.
I think this is the parent.
I would think so.
It was stated that ISFC could be paid on a time-limited basis through the use of static criteria, but the most recent ACL regarding LOC rates stated that the ISFC rate could not be lowered anymore. So once used through static criteria, it is no longer time-limited, correct?
That is currently a temporary policy while we're doing further analysis of the tool. So the policy of lowering the rate stays the same right now until we issue further guidance.
How is the TFC model, are there lockouts of other Medi-Cal specialty mental health services on the days that TFC is planned?
Yes, we have lockouts, and for those of you who are not privy to language that we typically use in mental health, lockouts mean that when a TFC service will be provided to a TFC child, other specialty mental health services cannot be reimbursed. So we have a lockout in that sense. I am looking right now through the manual to locate where we speak about the lockouts to remind myself of what those are, but I do want to say that yes, we do have lockouts. The one that comes to my mind immediately is that we have a lockout when children or youth are placed in a psychiatric inpatient hospital. So when the child is at that hospital, TFC services will not be reimbursed. Similarly, if the child or youth is detained in a juvenile hall or otherwise considered an inmate, again, TFC services will not be reimbursed. We also have a lockout that if a child or youth needs to be placed in an STRTP or other residential setting, again, for those instances, TFC services will not be reimbursed. The exception to both when a child is in a psychiatric inpatient hospital or an STRTP is that we will reimburse TFC services for the day of admission or the day of discharge to or from those facilities. And for reference, I'm looking at page 47 of the Medi-Cal manual, and that is where you will find that information that I just provided.
Can you explain the criteria when an ISFC child progresses therapeutically so they would no longer be ISFC/TFC eligible?
Say that again.
Can you explain the criteria when an ISFC child progresses therapeutically so they would no longer be ISFC/TFC eligible?
So I believe Teresa explained how the child no longer qualifies for TFC if they don't need the service. For ISFC, it would be the same thing. If their needs have changed, then what we have defined that as what we call a triggering event. Then we have another level of care protocol conducted, and then that's when the rate is changed. But all that is also in the context of what is discussed in the child and family team.
And for TFC, as any other specialty mental health service, there needs to be a child or youth client plan that must be, that actually is established, that includes the specific interventions that the parents will be providing as well as treatment goals. So I think that is used as a tool to evaluate whether or not TFC services are being successful and whether or not another service needs to be considered. So it's not a criteria, quote unquote. I think it's really about what is included in the client plan and whether or not those interventions are being successful in achieving client plan goals.
Here's a question for ISFC, which I think you answered, but does bio-adoptive children count towards children in the home for ISFC placement limits?
The total is total children. The total number of kids is 5. That's a capacity limit, and included in that 5 is the bio children.
With TFC being an EPSDT benefit, how would these services be provided to Medi-Cal beneficiaries that are not currently in the foster care system? If it was found that the beneficiary met medical necessity for the service.
Well, I think I've spoken about this in the sense that, I mean, you wouldn't have a traditional placement and you wouldn't have other factors that exist when a child or youth is in child welfare or foster care. However, the service itself doesn't change. I mean, the service would still be provided by a foster parent that is a TFC parent. The provider doesn't change, or the oversight structure doesn't change. The service itself, how we've thought about the service and the model itself doesn't change. I think that here the different factor is that the child is not involved in child welfare, probation, or juvenile probation, foster care, or child welfare. And sorry that I'm repeating myself. I think I'm just trying to talk really fast right now. So that would be the factor that wouldn't be there. So it wouldn't be a traditional placement. This probably would occur through a family identifying that a child or youth needs this level of service. So, I mean, it's, as I said before, it's hard to identify all the nuances that may occur for this specific situation. And again, it's a service that it's available regardless of whether or not the child is in child welfare.
All right. So we know that we have a lot of questions that we haven't been able to answer, but unfortunately we're at the end of our time. So here's what we're going to do. Because you entered your questions into the text box, we will have a log of those questions. We will share those with all the presenters today, and we will send an email with the responses. We want to thank everybody. Thank our presenters, Teresa Castillo, Cindy Culkin, Cheryl Treadwell, and Daisy Braxton, and thank all of you in the audience for attending. Here are some contact emails also and websites in case you have additional questions. We encourage you as you're exiting the webinar to take a few minutes to share your feedback. There is a brief survey. And with that, we will conclude our broadcast, and thank you again for joining us.